thank you for a wonderful presentation. Okay, I'm going to do my moderator privilege again and ask the first question. So, short of cloning you and putting you in kinds all over, I wonder if you have thoughts about, sort of the disconnect between the first presentation and what's happening nationally in so many places, and all the things that you're doing about how do we take this,
Yeah, the one thing that, I was most shocked about being from law enforcement is when they started talking about the Safe Needle Exchange, the program. And at first, when I heard this from the health department, because we haven't done it yet, we've done a lot of research, and they've been talking with Baltimore City, who has a pretty robust program in place already. And we're kind of teetering with it, and they're getting a lot of information. But when they brought it to me, as a law enforcement, I'm thinking, well, we're enabling these people. Like, we're going to encourage them. It just didn't sit well with me. But the more I started talking to the health department, and I realized, look, these people are going to use either way. They're going to use either way until they can get treatment. So why not try to go and do whatever we can to prevent the infectious disease part or them overdosing? And there's so many other programs out there. So I've been more open-minded to that side of it, which I was surprised to learn of myself, because at first I'm like, oh, no way would I do that. Like, no way would I encourage that. But the more I started hearing from Baltimore City and the health departments, it kind of goes back to that we got to think outside the box. And if our job is to prevent people from dying, then that's something that we need to look into.
Yeah. So do you have any thoughts for that last newspaper article about potentially closing some of the syringe exchange programs? Who should the deliverer of a message be? What do you think might be important to?
The message should come from the health department for sure. I think the law enforcement side could play a vital role in that. And, it's like Leo said, we're not looking to charge people with dirty needles or paraphernalia. I think we've made that pretty clear. But as far as that program goes, it definitely should be a push from the health department. I'd be interested to see what Baltimore City Police Department does, their role in it, which I'm not familiar with. Because, like I said, it's probably when the last month that I've started saying, you know what, this might be worth looking into. So that was something I would definitely be willing to dive into with the other jurisdictions that have been incorporating that.
Leo, do you have anything you'd like to comment on concerning that?
I think that, can you hear me?
Yes.
Okay, great. I think that I agree that collaborating with sister agencies is really critical, and I do think that the way to approach getting police on board is through, trying to find common ground, such as the thinking about, how does syringe exchange and other harm reduction programs benefit police? That's the intrinsic motivation part that I mentioned before. And we've found that that's something that really opens the door to getting officers, especially street-level officers, patrol officers, to sort of shift their mindset around harm reduction. I did want to mention one thing that bears highlighting here, which is that we are seeing, as Katie was talking about, the what's sometimes called drug-induced homicide or manslaughter prosecution. So this is a police side sort of policy innovation that is spreading relatively quickly in the United States. And I just wanted to show, if I could, some data on that, that I'm actually working on a project right now. Let's see here. So it turns out that, and I don't make any claims about what's going on in the jurisdiction where Katie works, but when we looked at the folks who were charged with drug-induced homicide or similar, subject to similar prosecutions nationally, we found that actually about half of the people who are charged are partners or friends of the deceased overdose victim, and that so that really sort of shed some doubt onto the idea that a lot of these prosecutions are leveled against, bona fide dealers. We also found that the race of folks who are charged with these crimes, it tends to be, it's usually, or often modally, it's people of color and as a dealer and a white victim. We also found that the average sentence is about 7 years that's imposed. And so in the context of this crisis, I think one of the concerning things, at least to me, is the disconnect between what Katie mentioned, the Good Samaritan Law, which is designed to encourage help seeking, and these drug-induced homicide prosecutions or manslaughter prosecutions, because folks, and this is not conjecture, this comes from research, folks who use drugs express a lot of concern about being charged in this way, given that a lot of these prosecutions are very visible and are often announced as a way, the thinking is we're going to deter drug dealers by making announcements about prosecutions, but in fact, it changes the informational environment for users themselves. And so there's essentially cross-purpose messaging happening. On the one hand, we're saying there's, an amnesty for people to call 911. On the other hand, we make announcements about people doing, significant time and deploying, as Katie was mentioning, homicide investigation teams. Oftentimes, those teams are, essentially at the scene while they are on the scene, and so they are conducting criminal investigations in a context of, an accidental overdose. And so there's a bit of a sort of laws acting at cross purposes here, and I just wanted to highlight this fact. Just it happens that I'm doing some research on this point, so that's something that I wanted to submit to all of you. Thanks.
Yeah, just I guess my comments on that was I can only talk about the cases that we've charged 3 individuals on manslaughter.
Absolutely.
So the 3 that we've charged were all white. One was a male, 2 were males, and one was a white female that was charged. The victims were all white males. And 1 white victim. And they were not associates as far as friends. It was strictly a business dealership where that was their dealer. There was no association other outside than them traveling to their location to buy the narcotics. I can see your point as far as where that happens more than not. Just the cases that we've talked about, that I've talked about, that we've dealt with in our county, that has not been the case with the ones we have. Not to say that's not going to where it's going to go, but that's kind of what we're experiencing right now. But what's alarming to me is, when we started talking to communities and me telling them that, hey, we're not locking up the person, your family member, I've had mixed messages from them, because now they're telling me, I wish you would lock up my kid, because if you locked him up and he was in jail, he wouldn't be able to use any more heroin or narcotics, and maybe it would stop him and get him the help that way. So it's kind of a double-edged sword. I feel like we thought we were doing something good, but then when you hear these parents who have lost a kid and they're telling me, hey, I wish you had locked him up and put him in jail, because maybe that would have got him to stop using. I don't think that would have been the answer, but I can see the desperation with these parents because they don't know what else to do.
I couldn't agree more with you, and I think that is something that is really put the rise in involuntary commitment in the U.S. So currently, we went from 13 jurisdictions to, I think, 38 jurisdictions that authorize involuntary commitment, where parents, people who are in crisis are really leaning on the state to coerce their loved ones. By and large, sometimes people are committed by other authorized persons, but by and large, it's families who are committing folks. And I can't speak to the United States as a whole, but in Massachusetts, where I know the situation very well, there are a couple of major problems with this. The critical one is that when people are locked up, whether it's through civil commitment or incarceration, they're by and large not receiving evidence-based treatment. And there are obviously civil liberties and other objections to locking people up, but even, in the context of sort of harm reduction, if you're going to take people into custody and people have opioid use disorder, they should be at least given the option of receiving evidence-based treatment. As a rule, they are not. And as a result, I think it bears mentioning, both with involuntary commitment and incarceration, there is the major problem of fatal reentry, which is that when people are eventually released, as people will be, right? So people are doing significant time or short time, they will have detox, and so they return to the community, and as is predicted by what we know about opioid use disorder, they often return to using, so they relapse and they die at very alarming rates. So the overdose rate post-incarceration in Massachusetts is 56 times the background rate. When you compare people who go into involuntary commitment versus those who enter treatment voluntarily, involuntary commitment has a 2.2 times higher odds of fatal overdose. And so, we have a commitment to, it's an ethical imperative to figure out how to deploy these interventions that actually reduce harm and not enhance it. And so I think, the bottom line for me actually goes back to what you were saying, which is that families are desperate. And that graph that I showed earlier, where folks who have overdosed and survived, a lot of those folks should be on treatment. I'm not saying everyone, because obviously everything has to be patient-centered. But opioid agonist therapy is proven to slash overdose rates by 50 to 80% or higher. And so the fact that so many of our, post-overdose sort of regimens and interventions don't include access to opioid agonist therapy is frankly shocking. And there are just very, very few doors. I don't know what the situation is like in your county, but even in Massachusetts, it has a relatively robust treatment sector. There are just very few doors, and there are very few resources for folks who are in crisis to be able to access help on demand. And, before we turn to these coercive modalities, we have to at least, give folks an opportunity to enter, to seek help voluntarily. And that's not what we're doing. We're kind of jumping that step and forcing people into, either through correctional system or the civil commitment system, into settings where they're frankly not getting helped and are just being warehoused, and that's not appropriate.
I agree.
So we have a number of questions.
Sorry to interrupt.
I'm sorry.
I just had a quick point to that. I just wanted to add a quick point relating the issue of involuntary non-evidence-based therapies to infectious diseases. To say that Leo and I have been doing a bit of work on the U.S.-Mexico border, where in Tijuana the government has actually expanded funding for these compulsory abstinence-based treatments, which have been associated with exposure to those have been associated with an increase in receptive syringe sharing among people who inject drugs in Tijuana. And some subsequent modeling work that's been done by Nick Borquez in our group has shown that the expansion of those programs could actually fuel the HIV epidemic among people who inject drugs. So really actually making the problem worse in terms of not just the overdose outcomes, but also the infectious disease outcomes. So clearly agreed that we need to ensure that people have a place to go to access services, but that they are voluntary and that they're evidence-based.
Mm-hmm. I agree.
So I'm going to alternate between the online and people in the room. So why don't we go ahead and take one question from the room, and then I'll do one of the folks participating.
Yeah, thank you for both of you. I'm Sandy Springer from New Haven, and while I was waiting to ask my question, Leo actually pointed out one of my major points. But thank you. You're doing a great job with what you're doing. But I do work with the incarcerated population, and particularly those coming out of prison and jail, and my work has been focused on the intersection of opiate use disorder and HIV and improving those outcomes. And working with this population, as Leo said, when many of those drug dealers, some of them are also drug dependent as well. And I don't think I have to, Leo already said it more eloquently than I did, that when we take such a hard line, we're not going to be improving their health, because we, as you know, we incarcerate more individuals than any other country. And they have 8 to 10 times the rate of opiate use disorders. And the majority don't provide any effective medications prior to release. And the number one cause of death of all released prisoners and jail detainees is opiate overdose, regardless of how long they've been incarcerated. So although I really appreciate what you're doing, I think we have to take both. We have to somehow figure out what's the best way, and not just incarcerating them, obviously, if they're doing something bad, and they should, but thinking about how we can effectively link them with first assessing them for substance use disorders and other harm reduction, HIV testing and hepatitis C testing, but also thinking how we can link them with treatment. The other thing I was wondering about is you had said that you're linking them with residential treatment. So a lot of those treatment programs, especially that I'm familiar with, are detox kind of based treatments, and we know that detox doesn't work. Detox is just like the same thing with forced incarceration they're going to use. So when people are failing treatments, are they failing treatments, these detox facilities, and should we be considering what I've been advocating, and everybody else that's just talked yesterday as well, as advocating linking them with effective medications like opiate agonist treatments or even extended release naltrexone. So that would be one. And then when I think about women who are involved, and particularly those who are arrested, many of them are not necessarily involved with the drug trade by personal choice. They may have also being forced to do so. And to say that one of your treatment interventions is to force them to go into a residential treatment program, which may impact their ability to stay with their children and some other things that actually could be a deterrent. So I'm wondering if there's ways to consider linking them with community-based treatments services as well, as because that can actually be considered a deterrent.
There is no forcing into treatment. This is all volunteer.
Right. But the treatment is your treatment that you're offering?
No, it's all, our mobile crisis folks are clinicians. They're responsible for getting them into these facilities, but nothing is forced. It all has to be volunteer, and they can walk out at any time they want.
But just what are the treatment facilities?
That's not our side of the shop. That's where we partner up with the health department, and they handle that part of it for us. But we don't force anyone into those facilities. And I hear what everyone's saying about the ones that we're arresting, which we look at the dealers, not the ones that are using in the overdose ones. And we're very selective on the cases that we go forward with prosecuting. And these are people that we've pretty much vetted and seen, hey, they've contributed to 7 people dying because of something that they've sold. And you also have to remember that we're the ones that are dealing with the families that have lost somebody, and they're looking at us for answers and saying, who's responsible for killing my child? And it's no different than taking a gun and shooting them. Someone killed their loved one, and they're looking at us to get results and to get answers for them. So we're at a fine line. I can't completely turn my eye on the law enforcement side of it because we're in the business of locking up dealers. So we're very selective on who we go forward with charging. And like I said, if it's somebody that's just completely overdosed and we show up on scene, we will never charge that person for overdosing. We're looking at the person that sold them that fatal overdose. And most of the time, that person has been linked to 5 or 6 other fatal overdoses before we end up charging them.
Okay, thank you.
Let me do one online and then, okay. So this is a question from Maxie McLain, and the question is, to what extent have Anne Arundel County law enforcement efforts to respond to the opioid epidemic been guided and directly supported by the state of Maryland's declaration of an opioid state of emergency and state funding announced in 2017?
we were ahead of it. So in 2015, our county executive, which was Steve Schuh, declared it already an epidemic. So in 2015, we were already taking these measures. And then 2017, the governor came on board and declared a state of emergency. So I'm glad to say that Anne Arundel was kind of ahead of it. And we'd already had these programs in place. And then when he came on board, it just created more funding, more things for us to do, more mobile crisis units to help us out. So we've been piggybacking off of that, but I'm happy to say we were ahead of the game on that before the state declared it an emergency.
Okay, it's your turn.
Hi, Todd Korth from Portland, Oregon. I have a policy question for both of you that relates to the churn that we see clinically in our patients who are hospitalized with very serious life-threatening infections. We do our best to treat those infections in the hospital. And in Portland, we begin buprenorphine or methadone in the hospital with a plan to transition that patient to the community immediately after hospitalization, except the bump in the road tends to be legal issues. And someone who has warrant issues or otherwise ends up going back to jail after hospitalization. It creates this situation where there's this gap in treatment. It also increases the length of stay and cost of care because we're not going to release that patient until their course of IV antibiotics are finished if we know there's going to be a treatment interruption going into an incarceration setting. But more importantly, there's also in many states, depending on the length of stay in jail, loss of Medicaid. And so you start someone on an appropriate treatment for their opioid use disorder. They go to jail. Some jails may offer buprenorphine. Some jails may offer methadone continuation. Most don't. And then they don't have Medicaid. They can't get into another provider that can quickly treat them. There's a gap, and they're at marked risk of overdose, relapse, and return to the hospital for recurrence of their life-threatening infection. Are there policy solutions that could come together and bridge this gap between loss of Medicaid and continuation of treatment to make things more seamless for people who use drugs?
Leah, I'll turn that over to you. I mean, for the law enforcement side, we don't really have much to do or say, a voice in that way. It's not in our fight. But Leah, you might be able to comment more on that.
Yeah, so I think this really does go back to what I was mentioning before, which is that laws are a societal normative statement about how we approach substance use and its related harms. The Social Security Act includes a provision that actually bans the use of Medicare dollars in correctional settings. I've previously written with colleagues advocating that exception be withdrawn. There's really no empirical reason why we can't continue people's health insurance coverage in correctional settings, and it's one of the reasons why correctional settings are so under-resourced in terms of their health care. And that's a legal sort of statutory fix that is needed and is way overdue. But there are correctional settings that are sort of trying to work with that provision and at least not suspend people's insurance policy instead of canceling it, because cancellation imposes an enormous barrier for people to be reinstated. So if the policy is just suspended, it can be reinstated much faster. Reinstating health insurance coverage should be standard practice for pre-reentry process, and as should be bridging folks to treatment, whether it's substance use treatment, getting, as you said, people tend to get stabilized on medication if it's any, other than opioid agonist therapy. So but many times there's a gap between that care then is discontinued. And as you said, people tend to be non-adherent and end up kind of spiraling. We need to do much better in terms of that bridging from the correctional settings into the community. And, in many ways, because there's a disciplinary disconnect between corrections and public health and healthcare, that is not being done. And there are examples, thankfully, there are examples of this being done well, and we need to build on those examples.
Thank you. Let me do one online question, then we'll go back to the room. This is from Rachel McLean, and it's to you, Katie. First, she said, thank you for your support of naloxone and access to drug treatment. Her first question was, can you say more about airborne ingestion of fentanyl? Have these cases been documented?
Yes, they have. So it's airborne. So when you walk into a room, so if it's a search warrant or just we're there to help somebody because they've called in for an overdose, a lot of times those drugs are sitting around and they're not nicely neat packaged in bags that are sealed tight. They're out there because they just used. So what happens is when officers rush in, when they rush in, brings in that sense of wind and it flies into the air and it's particles that you don't even see. It's actually going into our skin. We're inhaling it. So just that little bit of heroin, and we all know how fatal just a little bit of heroin is. We have a great slide, I wish I had brought with it, where it shows you the overdose amount that it takes for heroin compared to fentanyl, which is very, very minute. And then when you get to carfentanil, which we've had 6 cases last year of people overdosing on carfentanil, which is even like a grain of salt, that people can die over this. So imagine first responders, whether it's fire or police, are going on to these scenes. It's airborne, so it's around us, and it's getting ingested into our skin and through our nasals, where we're starting to feel those side effects that you would feel for an opioid overdose, where we've had 2 of our officers have to physically be transported by medics to the hospitals to get treatment. We've seen it across the region where officers had severe exposures. One went into cardiac arrest where they had to get medical treatment, which is why we stopped the field testing, which is why we glove up before we touch anything that's a white powder or anything that we suspect could be an opioid. So it's become a great risk to first responders, to police and fire, when we're getting exposed to this.
All right, let's go back to that.
Hi, Jessica Teitel from the HHS Office on Women's Health. Excuse me. I wanted to build on something that Dr. Springer said about women, particularly moms, and their accessing services. One of the challenges when you talk about women who may be using drugs or who may be living in a household with people who use is their hesitancy to involve law enforcement or become involved with the legal system because they don't want to potentially opening the door to CPS and potentially losing their children. And so I was hoping that both of you could kind of speak to that, maybe from your local experience, but also from a more national policy perspective on that issue.
Sure, I couldn't agree with you more. And I work very closely. We've got a couple of houses, facility homes for just women in our county, Chrysalis House being one, Hope House being another one, where I work with these women constantly, because you're right, there's a fear of law enforcement with them, and they're scared to death we come in their house, that we'll take their kids away from them, and that couldn't be further from the truth. So part of my job is going out to these facilities and talking to the women and ensuring them that we want to see you get help. And our goal is not to separate you from your children. We want to see you get into a healthy environment for you and your child, to see you succeed in that development. But a lot of that comes to just building relationships and trying to get them to overcome that fear. So I'm going Friday night to go talk to a new group, because they turn over about every 60 days, new women, and they bring their children with them, that they've actually voluntarily gone there to get help, to get over their abuse. I probably go there every 3 months, and I talk to a new group of women. There's about 60 of them, and they bring their kids, sometimes their babies, and I talk to them. And not only about the abusive part about it and the opioids, but I talked about what they can do if they're a victim of domestic violence, if they're in a situation where they're scared and they can't get out of that abuse. So I give them other avenues of ways that we can help them. So it's not just, hey, let's help you with your addiction. Let's also help if you're in an environment where you need to get away from it. And a lot of times it comes back to domestic violence. So I give them resources. I talk to them. I tell them what they can do to protect themselves. We try to work with them to get them out of those environments. So I do a lot of work with women that have addictions.
If I can just add a little bit to that. So it's heartening to hear Katie talk about this. That's, in my limited understanding more of an exception than the norm. I think that, CPS and sort of the foster care system figures very prominently and as a chilling effect to health seeking. And that includes calling for help when there's an overdose, and it also includes treatment access. So this is shocking to me, but it's standard practice for CPS to get involved when people are on opioid agonist treatment, and that can be, being on opioid agonist treatment can be the basis of your kids being taken away, and again goes back to the pervasive stigma that really defines not just laws on a statutory level, but also institutional policies that are really nonsensical, and we haven't really been able to translate what we know about the benefits of evidence-based treatment into policies on that side. And it also bears mentioning that there are many other elements of the policy environment, such as housing, for example, public housing, and how help seeking is chilled by the policies around, substance use and quote unquote sobriety in that space. And then there are many, many other examples. So, there's a lot of work to do in aligning what we know works and what advances public health, both on the infectious disease side, overdose prevention, and other issues.
We are coming to the end of our discussion period, but why don't we do...
well, this is more of a comment, I suppose,
yeah.
anyway. But so thanks very much for being here. I think it's great, and often in this conversation there's no law enforcement involved, so I really respect you for being here and appreciate that.
Thank you.
I want to challenge you on one thing that you said. Well, you said it twice, where ideas were brought forward and the response was, well, that's beyond the law enforcement boundary. And I'm just not sure that's true. I
Are you talking about for the medical part of it?
Well, yeah, and thinking about policies in jails, thinking about health insurance, the whole thing, right? This is an epidemic, as you pointed out, and I think that as law enforcement, you have more power than you think.
No, and I was just pertaining to people not having the medical insurance to get the help. As far as our correctional facilities, we work very closely with our correctional facilities. We meet once a month with corrections, police, fire, health department, mobile crisis, to try to tackle those. No,
and I appreciate that. And I think that's a great point. Obviously, law enforcement can't fix health insurance in America.
Right.
That said, a police department or a state police department coming forward to say this is an issue and this loss of insurance is an issue, and we as the police force think we should be working on this, would be really, I think, effective.
I would be the first one to stand up before a delegation and say that and support it. No doubt about it.
Yeah, I think that's important. I just think that's important to as the police, you guys have a lot of cultural power.
And that's why anytime I'm invited to any kind of venue, I don't care what the audience is, I will come and talk about it. And if you ask me to support your cause, to go before senators and delegates, I will be the first one there saying, yeah, we need to do something, not just as a captain of a police department, but also as a citizen of Anne Arundel County that wants to see us do something about this crisis.
Great. Thanks very much.
Absolutely.
Since you outrank me, Carlos, I'll let you
just a really, quick but complicated question. Thank you for being here first and for your both presentations. One issue that we face a lot when we go talk to community is that we've changed our approach. And we've had opioid addiction and drug problems with our African American population in Atlanta for a long time, and the role of police has been to incarcerate people. And now it's mostly a white problem, and now our role is to be compassionate. We have all this Good Samaritan laws, et cetera. And there's a lot of tension in the community saying, hey, there's a lot of racism involved in all this. Mm-hmm. How do we deal with that? Because it's a reality. And how do you expect the African American community to trust the police after this has gone on for years?
That is a great question, and it is a very real question. Working in Western District, which in Anne Arundel County, I had 3 lower income communities. And when I took over that district, that was an issue that was brought to my attention. I spent a lot of time with those communities, and it comes back to dialogue and having conversations with them and talking to them. And you got to hear them out. You got to hear their concerns, and you have to validate those concerns. And then to build trust is like anything else. When trust has been broken, which takes very little to break trust, and we all know that trust has been broken with those communities, it takes a long time to build that back up. It can't be done overnight. It can't be done just a one and done. You go into that community once and talk to them and leave. It's got to be continuous and over time. I worked in this one district for 3 years. I've made some great friendships. I made some great partners in those communities where they started listening to us and we started building that trust back again. But it takes time. And they have valid concerns. And I listen to them all day long. And I love talking to them. I want to hear their side of it. Just like they need to walk in our shoes, we need to walk in their shoes also. And with the younger generation in those communities, they need to see law enforcement in a different light. You know, those communities, they see law enforcement coming in their communities and locking up their mothers, their fathers, their friends, their uncles, their brothers, their sisters. They have got to see us in a different light. So a lot of things that I did when I took over that district is I had our officers go in those communities and playing basketball with them, kickball, bringing ice cream out to their neighborhoods and handing it out on first day of school, taking them to the National Aquarium, taking them to the parks, taking them to a Bay Sox game. They had to start seeing us in a completely different light than what they were seeing us, because those little things that we're doing for them starts instilling that trust. Well, they'll say, you know what, they're not all bad after all. But it comes back to building those relationships and creating dialogue with them. And it's got to be continuous. It can't be just a one-time deal and then you leave that community.
So I would say that I have been involved a little bit and learned from something called the Policing Project, which is this organization run by lawyers essentially, and the police, which essentially tries to do that. It's a really good sort of intermediate glue to try to bring the police and the community together and try to create that trust. So I think, yeah, having an intermediate in between may be something that would help.
The sad thing is community-oriented policing has been a long-term philosophy. It's been around for years, and we got away with it for a while. And now in the last 5 years, you're starting to see agencies that it hurt us by getting away from that philosophy because it was damaging those relationships and that trust. And now you're seeing communities that are really jumping back on that bandwagon where you're going to fail as an agency, as a police department, if you don't have those communities' trust and the partnerships. Because when that critical incident happens, you can't ask them to trust you right then and there. You got to build that trust before that critical day comes.
So in wrapping up the session, I'd like to thank both of our presenters, and I'd like to particularly, Katie, thank you for coming here as a former Marylander and now living in another state. I would just like to really reinforce again that this dialogue is sort of the first step in sort of making differences, and so I appreciate you coming before what is sometimes kind of a tough audience, and I hope that we do recognize change happens in small steps, and that it's really important in continuing the dialogue. So
Thank you for having me. Thank you.